Hello and welcome to another episode of ICU Doc Talk. Thanks for joining me today. This is a podcast about medicine. I am a double board certified anesthesiologist and critical care physician. I work at a major American academic hospital, and I specialize in anesthesia and intensive care and also ECMO. I work at a cardiac ICU, and I am also an ECMO practitioner, which is a heart-lung bypass machine. This is a podcast where I talk about medicine, many different topics, and also talk about politics occasionally. And I always talk about books, nonfiction and fiction. I talk about history, lots of stuff like that. So today we're going to be talking about trauma anesthesia, resuscitation, and getting someone through a traumatic injury from the ER or the ED through surgery and into the ICU. And then after that, we're going to just be discussing some books. The two books today are Genghis Khan and the Making of the World by Jack Weatherford. It's all about the Mongolian Empire. And then another book I'll talk about is A City on Mars. Can we settle space? Should we settle space? And have we really thought this through? By Kelly Weinersmith and Zach Weinersmith. Both great books that I'm going to get to at the end of the episode. And then maybe we'll read an email or two from listeners writing in. So let's get started. All right, so the topic today is trauma anesthesia. So what that means is people undergo traumatic injury all the time out there in the real world. Accidents happen all the time to anybody at any time. In fact, for some certain demographics, accidents are very high or the highest cause of death for some, teenagers and other demographics. So accidents are a thing. Traumatic injury, of course, are a thing that can happen to anybody at any time. And when someone has a traumatic injury, and I'm going to cover many different, lots of different kinds of traumatic injuries. They come in by an ambulance. The scenario I'm going to be going over is they have a traumatic injury, whether that's a car accident or they fall off a roof, or they are longboarding down a hill without a helmet. There's unfortunately no end of ways that people can harm themselves in traumatic injuries. They come in through the emergency department, they get resuscitated there, and then they'll come to the OR, and then they'll go to the ICU. That's kind of a scenario I'm going to be discussing today, and the role of an anesthesiologist and a critical care physician in doing that. This is something I have a lot of experience with resuscitating someone with a traumatic injury. All right, so let's say someone has a car accident. Now, there's different trauma levels of different hospitals, right? There's level 1 trauma where all big traumas get routed to that by ambulances to hospitals that can care for them and have the capabilities. So, and I've worked at several level 1 trauma hospitals, so I've been in part of major traumas many times. And I want to make something clear. I am not an emergency medicine doctor. That's a lot of people get confused that with an intensive care doctor. So I'm not talking about the role of emergency medicine here. That's not my role. So let's say a patient gets in a car accident. There's first responders to the scene. They resuscitate as needed. And I'm going to kind of gloss over that. And which doesn't say that is, it goes without saying that is an important part of resuscitating a patient are the first responders, right? So they resuscitate the patient, whether that's giving fluid, putting in a breathing tube, stabilizing things, right? It's a whole world that I don't actually even know that well, right? Because I'm not a part of that world. So the first responders bring in a patient that obviously is not dead, okay? But they might be close to being dead. But they bring in a patient, they have a pulse. Sometimes they don't have a pulse. Sometimes they're actively bringing in a patient that is actively getting chest compressions. They don't have a pulse, but hey, we can still maybe save this patient. So people come into the emergency, and again, they're coming to at this point, they're coming into the emergency resuscitation bay in the emergency department, okay? The first responders, EMS, are bringing the patient in. And as I said, sometimes they're actively shocking the patient's chest, usually not with trauma, because usually someone's problem with a traumatic injury is not that they have a shockable rhythm. Sometimes it could be, but it's usually like they're bleeding out, or they're herniating in their brain, or something like that. So it's usually a PEA arrest, pulseless electrical activity arrest, or an asystolic arrest. Usually, if they're arresting. So sometimes they have active chest compressions going. Sometimes they don't. Sometimes they have a breathing tube in. There's a whole variety of states that someone can be in when they're rolling into the resuscitation bay. So my role as an anesthesiologist, you want an anesthesiologist there for big traumas, right? Some hospitals, they call it like a red trauma or a code trauma, whatever. Like, hey, we got an alert. A big trauma is coming into this resuscitation bay. Anesthesia staff, please come down. So my role is I'll show up to that. And and I also show up when I'm for ECMO as well, because I am an ECMO practitioner. But that's a heart bypass machine. Sometimes I'll put someone on ECMO in the emergency medicine bay. That's another discussion. But sometimes we will deem that, yeah, let's put this patient on, and we do that in the emergency medicine and the resuscitation bay in the emergency department. But anyway, when I'm coming down there, one of the first things I do, I look at the patient with my eyeballs and I see what's going on with the patient. Are there active chest compressions going on? Just getting a overview, very quick, brief overview of what's going on. And then I really want to listen to what the EMS, the paramedic, their report. Extremely important to hear the report. I want to hear what kind of trauma was this, any detail. I want any detail that they're willing to offer. How long have chest compressions been going? What rhythms did they have? Was it, all of that. So that's one of the first things I do. I listen to that report. And then, how was the airway? What kind of airway do they have? Now, oftentimes a big part of anesthesia role in this is sometimes it's hard for EMS. I'll be using the term EMS for paramedics to put in a breathing tube in the field. They have to do. They do all the time, but sometimes they don't. Sometimes they put in different airway devices because they're easier to insert. They're less difficult to insert. You can get them in quickly, and then they come in. But they're not very secure airways, and there's nothing wrong with them putting these airways in the field. I'm not being critical of that at all. But sometimes they'll come in with like a King tube. A King tube is not an endotracheal tube. A King tube is it's kind of like a laryngeal mask airway, an LMA, but it has two balloons. It has a balloon that you stick this tube down their throat, and it has a big balloon they inflate in the pharynx, and another balloon that they inflate in the esophagus, and then it has a hole in the airway that over the larynx, and then you intubate or you ventilate through that. But notice there's no tube that actually goes past the airway. The larynx. So it's not a protected airway, but you can ventilate someone through this. If someone comes into the emergency department with a King tube, they're likely underventilated, and that is not a protected airway. And one of the big things you think about in the anesthesia world is if someone had a traumatic injury, they have a full stomach, right? Because they may have just eaten a Denny's Grand Slam breakfast, left, and gotten in a huge car accident. So they have a Denny's Grand Slam breakfast. For those that are not in the United States, that is an American restaurant where you can get a big breakfast like pancakes and eggs and bacon and stuff like that. Anyway, my point is you assume they have a full stomach. They do have a full stomach. Also, trauma slows down gastric motility right away, right? Your fight or flight response of the body is through the roof when you've had a traumatic injury. So you're not digesting anymore. So everything starts slowing down in the gut. Everything's backed up. You just have a bunch of food and gastric juices just chilling in your stomach. And all that stuff can go up the esophagus and aspirate into the lungs. Someone 100% can die from aspiration of gastric contents into their lungs. They either can die right away because you flood their lungs with a bunch of fluid and they just can't aerate, or they get aspiration pneumonitis, where that acid just inflames the tissue so much that they get acute respiratory distress later and they can die of that. It's very dangerous. Okay, it's very dangerous. So my point is you must get control of that airway right away. You have to exchange whatever airway, whether it's an LMA or a King tube or whatever multitude of other airways there are, you must exchange that for an endotracheal tube. Got to do that. Now, this is also the role of an emergency medicine doctor as well, right? There's a lot of overlapping roles in this space I'm talking about. In resuscitating someone in the emergency medicine bay, lots of overlapping roles, whether it's the emergency medicine doctor, the anesthesiologist, or a surgeon, a trauma surgeon who is also there. So a trauma surgeon also needs to be present with a big trauma. You have the emergency medicine doctor that's doing the primary resuscitation, the ABCDEFs of, airway, breathing, circulation. That's the role of the emergency medicine doctor, the initial resuscitation after the handoff from EMS. They're there, they're running the code. That's their responsibility, that's their expertise. Anesthesiology and a trauma surgeon are also there right away in big traumas like this. Sometimes I'll assist with exchanging an airway. If it looks very difficult, I'll help with that. Maybe I'll help with placing lines, whatever. I'm just there to kind of help. But the reason I'm also there is to then, hey, this patient needs to go to surgery right now. I now then can take that patient up to surgery, right? And then resume care and become that primary physician along with the surgeon. That's one of the other big reasons that I am there as an anesthesiologist. Okay, the next thing, after airway stuff, and again, you're resuscitating the patient, maybe you're doing chest compressions, maybe you have ROSC or return of spontaneous circulation. That's where you got a pulse back. You might be in between these things, right? People can arrest, you get them back, they can arrest again 2 minutes later, and away you go. You're trying to save this person's life. Whatever their age is, whatever, right? Now, the next part of this is hemodynamic stabilization, right? So people are often in hemorrhagic shock from a traumatic injury. Often, not always, of course. But one of the reasons that they're trying to die, is they're in hemorrhagic shock. That just means they've lost so much blood in the field, or they've lost so much blood into their belly or into their thigh, right? If you break your femur, you can, or into your chest cavity, right? You can exsanguinate, lose all of your blood into your body, internal bleeding. Sometimes we refer to that as internal bleeding. So you can lose all of it and you can die without blood really coming outside of your body. So someone could be dying by that. So they're often in hemorrhagic shock. So you are giving blood products, you're giving fluid, whatever you can get your hands on right away to keep things circulating, right? And that also involves giving epinephrine or norepinephrine and vasoconstrictors to raise the blood pressure, raise the systemic vascular resistance of your system, and also raise your heart rate, raise your cardiac output as much as possible to keep this patient alive. So part of that management is giving blood products. We sometimes someone is losing so much blood. So there's a clerical issue with getting blood products to a patient, right? There's a system in place. Now, administering blood products to a patient is something that must be done with a lot of care. There's a whole system in place to make sure you give the correct blood products to the right patient, you give the right blood type, all those things, right? So because of that, there's a bureaucracy in place, a much needed one, that delivers the correct blood products to the correct patient. What I'm getting at is sometimes it takes time to get blood products to a patient. Sometimes it takes time. And sometimes you don't have that time. So if I need to give 2 units of blood to a patient that just had cardiac surgery and they're stable, but they just need some blood, we can wait 20 minutes, 30 minutes for that blood to arrive and do an appropriate cross match. To where they take a sample of that patient's blood, they take it to the lab, they compare it to the blood that they're going to get, they make sure there's no antibodies. We got time for that. In the trauma bay, you don't have time for that. So you got to get uncross-matched blood to that patient. Uncross-matched blood is where it's blood that's transfused without performing that cross-match test, which is used to ensure compatibility with the donor and the recipient. So you just don't do that in an emergency. You just give them O-negative blood. That's the universal donor blood, right? So no patient is going to have antibodies to O-negative blood. Now take that back. You may have some antibodies to that blood. So there's there's risk. There's always risk giving uncross-matched blood to a patient. But you got to use it in an emergency. And sometimes a lot of hospitals have a protocol, in the United States at least, we call it MTP, or Massive Transfusion Protocol. So when I say, hey, I need an MTP for this patient, what that means is that's a very serious situation. Someone is in severe hemorrhagic shock and they're going to die. I need a cooler full of a bunch of blood products right now. That's what you're saying. I need it right now. I need it yesterday. Bring it right this second, uncross-matched blood, and we're going to pour it into this patient to save their life. An MTP comes with blood. It comes with packed red blood cells and FFP usually. Maybe it may come with platelets. I don't think it does. I think it's got to come on top of that. That's part of your management is giving this, pouring in blood to these hemorrhagic patients, right? And now they're also becoming coagulopathic. So they're having a mechanical bleed. Okay, a mechanical bleed, meaning there's there's a vessel in their body that's open and they're bleeding through that. But then they're also developing a coagulopathic bleed where their clotting factors now are no longer clotting off and bleeding. That has to do with being cold. That has to do with undercirculating. That has to do with trauma to begin with. And that has to do with giving them crystalloids or colloids, which also which can help precipitate a coagulopathy. So you're causing a coagulopathy, the trauma itself and the resuscitation, and then they're having a mechanical bleed and they're cold. Being cold causes blood to not clot as well. So they have many, many reasons to be bleeding out. So you have to also resuscitate them with other blood with clotting factors, plasma, cryoprecipitate, Kcentra, whatever it is. You got to just throw it at them, right? Okay? So that's a big part of it. So you're doing this and then you're all on the resuscitation bait and you're trying to figure it out. Why are they dying? What's causing it? We think they have hemorrhagic shock. Where is the bleed, right? That's the next question you're going down. Maybe you're doing chest compressions. Maybe they've stabilized a little bit. Maybe their circulation is okay. You have a blood pressure. Maybe you're getting in some lines, an A line. It all depends on the situation, right? That's why the management is so important. The people that are managing this is so important, because, as I said, people can be dying for many different reasons. So you got to figure it out. That's what you're all there to do. So maybe now the next step is to get imaging. Maybe we need to send them to scan their body with contrast to see where they're bleeding from. Yep, okay, maybe we need to do that. Or maybe they're just bleeding out so much and you take an ultrasound machine, it's called a fast exam, and you look at their belly and you see blood in their belly and they're so unstable that altogether you decide, let's take this patient to surgery right now. We're going to do an exploratory laparotomy where we're going to open up their belly. We're going to try to find their bleed. Maybe their spleen is bleeding. Maybe they have a liver laceration. Maybe they have a hemothorax. Maybe they have cardiac tamponade, where blood is around their heart. Maybe they have, a cardiac contusion, pulmonary contusion. And you got to make that decision together. The emergency medicine physician, surgeon, anesthesiologist. So you just do whatever the patient is dictating that you do. All right. So sometimes that involves going and get a scan, and you see, they're bleeding in their pelvis. They need to go to interventional radiology right now to get that embolized. Or, they're having a major bleed from their spleen. They got to go to surgery right now. Or sometimes you just don't have time and you just rush to the trauma bay or to the operating room. Right there, you all go and they have surgery right away. Or maybe it's obvious that their femur is broken open and they're bleeding into that. Okay? Or maybe it's they have traumatic brain injury. Maybe it's their head that's the problem. And you scan their head and they have a compressive epidural and they need to go have a burr hole. They need to have a craniotomy with a neurosurgeon to open that up. Well, then I'll go with the neurosurgeon and help with that surgery, right? All depends on the injury. Maybe they need cardiac surgery, right? Now I want to make an interjection right here. You don't put someone on ECMO for hemorrhagic shock, okay? So ECMO does not fix hemorrhagic shock. I know that's like an obvious statement, but you got to fix someone's bleed before so an ECMO is just a pump. It's just a pump. It's also an oxygenator. That's what an ECMO buys you: a pump to perfuse someone's body and an oxygenator. So if the problem is with their pump, their heart, if that's the problem, and it's not pumping, like they have a heart attack, no, that's not trauma, right? Then ECMO, sure. Or if the problem is that they asphyxiated because they choked on something that they were eating, or they drowned, well, then you can put them on ECMO, right? So if the problem is not a pump problem and it's not an oxygenation problem, you don't put them on ECMO, right? So you do not put someone on ECMO for hemorrhagic shock. You got to fix the bleed and resuscitate them. ECMO won't work with hemorrhagic shock. ECMO needs flow. It needs to drain blood from the body and replace it with the body. And if they're in hemorrhagic shock and the ECMO can't flow, that is the wrong thing to do, right? But again, if I'm in the emergency department and it's a different scenario, someone's saying, hey, if they've had chest pain for the last 2 days and they were at work and their coworkers found them down right away, they saw them collapse and they did chest compressions and EMS came, and that was 30 minutes ago, and chest compressions have been going for 20 minutes, and it was a VTAC arrest. Yes, put that patient on ECMO, okay? Because they can get they can get a stent or something in their heart, maybe. You can stabilize that patient. Because their pump is not working. It's their heart. That's a heart attack. Their pump is not working. So give them a pump, right? It's pretty, the more I get in medicine, the more keeping things simple is really how you manage patients. Occam's razor, keep things simple. Don't make your decisions based on a bunch of assumptions. Look at what's going on right in front of you and go from there. That's really how you manage patients. It's the best way to do it. Keeping things simple, straightforward. All right, now let's go back to a scenario. Let's say we think a patient is bleeding out in their belly. They've had a car accident. Let's say they have a splenic laceration or something. I don't know. And we're just pouring blood in, and we're keeping them afloat. They have a pulse, but we're losing them fast, and their blood pressure's going down, and they're on monster doses of norepinephrine and epinephrine, really high drip doses, and you're floating them with bicarb, and you're barely keeping them alive. And let's say the surgeon, and this is obviously come down to the surgeon's call, right? They're going to be like, let's go to surgery. They're going to make that decision rather than, hey, let's go scan. Maybe they might, right? It's all up to them. And everybody together. It's a collaborative effort, of course. So let's say, okay, let's go to surgery. All right, let's go. Boom. So I'm going to take this patient to surgery. So I'm going to transport this patient with other staff. I'm going to make sure I have plenty of blood products. My main thing, I don't care necessarily if I have an arterial line at this point. Now I want an arterial line, okay? But let's say they only have a non-invasive blood pressure cuff, and I have an EKG, right? And let's say they have a breathing tube. So I have end-tidal CO2. But let's say like it can be hard to get an arterial line in a situation like this, right? They're so clamped down. Their SVR is so high. The body, their sympathetic drive is trying to maintain that blood pressure. Let's say they don't have an A line. I am not going to stop everything and put an A line. Nope. I'm going to take this patient to surgery right away. My main concern is venous access, is a large gauge venous access to resuscitate their body with blood products. That is the number one concern. Okay. So let's say I bring this patient to the OR. They don't have an arterial line yet, but let's say they only have 20 gauge IVs. I am not. So in this specific scenario, and I really want to make a point here. Let's say we bring him in. We're in the operating room now. We've brought them from the emergency department, and the surgeons are like, "Let's go," and they want to cut, and that's fine. They can, they're looking to me, be like, "Hey, are you ready? Can we do this? Are they asleep, etc." And that's another thing. I will talk about the anesthetic in a second, but I am not going to be like, "Wait, I need an A line." That's the wrong thing to do. You say, "Go." Maybe it depends on how awake this patient is. Okay. I'll talk about the anesthetic in a second, but they need large bore IV access. And if they only have 20 gauges, my priority is I want to put an 18 gauge, a 16 gauge, a 14 gauge. Those are large bore IVs. Anywhere I can get them. Okay. You don't need to put in a central line right now. You don't need to. In fact, in this scenario, you shouldn't be putting in a central line unless you don't have any other option. You should be putting in large bore IVs if you can get them, because that's the fastest way to get access. And you can resuscitate really well through a 16 gauge, even an 18 gauge, right? You can get blood in really quick. So your focus at this moment should be getting a large bore IV. It shouldn't be like, hey, now a central line is great, right? You can put in a large bore central line, and you can resuscitate really quick through like a introducer, or what we call a cordis in the United States, in the IJ. But your goal should be putting a large bore peripheral IV if they don't have one yet. That is the focus, because they'll die. They'll die without that. They can. So I got to ensure I want 2 large bore. If they have 2 16 gauges, or at least 2 18 gauges, and they're running really well, I am good to go. I'm not, and in fact, if you have that, you shouldn't be putting in a central line yet. You shouldn't. Not right now. Not in this phase where we're just starting surgery. I don't think you should be. You focus on blood products. You focus on getting those in, making sure you have it, and then also hooking them to a rapid transfuser. In the United States, we have the trade name is called a Belmont, which is something that you can very rapidly get blood into a patient, or a pressure bag. Put a pressure bag over blood transfusion. That should be your focus. It's the main issue. Okay, and then also managing your vasoconstrictors and your inotropy, epinephrine, norepinephrine. Now they're going to need a central line, of course, but you can do that at the end of the case after they're stabilized, right? You can put that in then. Or maybe you can put it in during if you really, really need it. But your focus is resuscitation, is volume expansion resuscitation, and then correcting coagulopathies. That's your focus. And running a code and keeping the patient alive. And doing chest compressions when you have to, stopping the surgery when you have to, saying, hey, you got to stop, you got to do chest. That's your job as the anesthesiologist. Okay, so you got that all ready to go. And then you need an A line, don't get me wrong. You've got to have an arterial line. And I would be putting that in right away as well once I ensure I have large bore IV. Or an arterial line. Why do you need an arterial line? Because you want to know what their blood pressure is every beat, right? A blood pressure cuff, you might know what their blood pressure is every minute or so, maybe every 30 seconds. But an arterial line, that lets you know what their blood pressure is every beat of their heart. And then you can also easily draw labs. And then you can draw coags. You can look at all their coagulopathy, okay? That is just your main focus. So let's talk about the anesthesia. Okay, now I say this a little glibly, but it's true. Death is a really good anesthetic. Okay, approaching death, the brain approaching death, that is anesthetized. Someone is anesthetized. What I mean by that is sometimes, so let's say I'm going to put in a breathing tube in someone who's getting active chest compressions. Do you need to give a paralytic and induction agents anesthesia to that patient? Absolutely not. No, you do not. All you do is put your blade in the back of their throat and put in a tube. You do not need to paralyze their body or anesthetize their bodies to put in a breathing tube in someone who's getting active chest compressions. Right? Just so I'm clear on that. You do not need to do that. You shouldn't do that because you're going to affect their blood pressure more by inducing them with that. Because dying, the process of dying, anesthetizes a patient. They have low blood flow to their brain. They're not conscious or awake. They might have that, but very, very likely they don't. And it's kind of the same thing with this is a corollary with what I'm talking about. So say they're going to get exploratory laparotomy, and the patients, now it depends on how they're moving around. Now they should be paralyzed for the surgery, just to be clear. I'm just talking about the breathing tube. So if they're coming in, I'm going to give them a big dose of rocuronium or whatever to paralyze their body so the surgeons can have surgery, because I don't want the reflexes to get in the way. Now it depends on how. Now of course I want to anesthetize the patient. So the highest risk for someone having awareness under anesthesia are trauma anesthesia and OB anesthesia. Those are the two types of anesthesia where someone is most at risk for having awareness under anesthesia. Why? Why is that? Well, it's not because someone's doing a bad job of anesthetizing them. It's because it's out of a necessity that we're not appropriately anesthetizing them, because it can kill them, because their blood pressure is in the gutter. They don't have enough blood product. They're not circulating enough. So if you put on too much anesthetic, you can kill them. So it's a choice. It's an active choice to not anesthetize somebody fully when they're undergoing trauma surgery. And that also goes with OB surgery. It can, right? When you're having like crash OB, a crash C-section or something like that, where the patient's very unstable, because it can kill them. So like, if I bring this patient to the OR and I hook up their breathing tube to the anesthesia circuit and I put on the anesthetic gas at full blast, maybe I didn't make it clear. Anesthetics are vasodilatory. They drop your blood pressure, like many anesthetics do. Volatile anesthetics, the gases, propofol does, right? They drop your blood pressure. So you've got to be, it's one of the most dangerous things I can give that patient is anesthetizing them. So maybe in this scenario where someone's bleeding in their belly, I bring them in. I make sure they have a large bore appropriate IV access, and then I make sure they have an arterial line, and then I make sure we have blood products. That's my main goal, keeping the patient alive. I make sure the body's paralyzed, and then I might put a little bit of anesthetic gas on, a tiny bit, and then I'm giving them benzos. Okay, that's my main anesthetic for this patient. Benzos, like midazolam. Now, is midazolam an appropriate medication for a general anesthesia? No. You're not going to get, you can have recall, you definitely can. But benzos are pretty hemodynamically stable medications. If the same patient, if I gave them a big slug, a big push of propofol, I can kill them. So I'm not going to do that. Okay, so I might start with 4 milligrams of midazolam, and then I'm dosing it. Okay, let's give another 2. Let's give another 4. Let's put on a little bit low gas. Oh, the blood pressure's in the gutter. Turn off the gas. Okay, give them a little more midazolam. Sometimes that's it. That's all the anesthetic they get. And depending on how well their brain is getting perfused, they may have awareness under anesthesia. They probably won't, though. They probably won't. From my experience, they usually do not. But they might. And that's, unfortunately, for that patient, is the way it goes. So they might have some memory of, yes, being in an operating room and having surgery, deep invasive surgery, and having awareness. It's definitely possible. But the alternative is we might lose the patient in the operating room and they might die. So that's how that goes. Now, let's say patients resuscitated, the surgeons have found the bleed. Now, there's this concept where you don't try to fix everything in trauma surgery. You fix up what's killing them, and then you pack them up and you send them to the ICU. And we find that patients have better outcomes. You don't try to fit. Maybe they might have other injuries, right? They might have some vertebral body fractures. They might have rib fractures. They might have a broken tibia. You don't fix all that at once. You just fix the thing that's killing them. You pack them up, you send them to the OR or to the ICU. So that often will involve leaving someone's abdomen open, because it can get really edematous, really swollen, and they might need to come back down to the operating room again the next day. They probably will with a surgeon for a washout to look for bleeding. If you pack that all up, they can get intra-abdominal compartment syndrome later in the ICU, which is where you get too much pressure in your belly, and it stops the perfusion, and someone can die from that. So, and that's called damage control resuscitation. You just get damage control, you pack up, you go back. People usually do better if you just focus on damage control. Now, this patient's going to have so assuming they survive, they're going to have a long hospital stay, right? They're going to be down in the operating, depending on what injuries they have, they're going to be in the operating room a lot over the next couple of days. A lot, depending on what's going on. And it's going to be a very difficult time for this patient and their family, assuming they recover and they get out of the ICU and PT and all that stuff. Like, they're going to be dealing with this for years and the rest of their life. So it's a big, big deal for someone with traumatic injury. Obviously, I'm stating the obvious. So we get them packed up, ready to go, and then we take them to the ICU. Okay, and then the ICU, and then I'm also an ICU doctor, so I will take care of patients in this sitting as well. And my focus is, hey, let's say they land in my ICU. Now I'm like, okay, are they my questions are my access is usually good because they've come through anesthesia in the emergency department, so I don't usually have to, maybe I need to put in a central line or something like that. I'm going to try what kind of presses are they on? Can I get down on these? But my main concern is they probably are still going to have an ongoing coagulopathy that I'm going to need to correct, and they might still be bleeding, right? Despite the surgeon's best effort and doing a good job, they can now have new bleeding manifesting, and I got to be vigilant of those things. And maybe now they're bleeding from a chest tube because they had a pneumothorax, a collapsed lung, but now they're bleeding out of that with maybe an intercostal artery got transected during chest compressions from a broken rib, and now they're really bleeding out of that. Oh, maybe now they're developing tamponade. Maybe that TBI is now blooming into something else, right? So all these other things can manifest. I got to keep an eye on all of these things. I'm focusing on correcting the coagulopathy, electrolyte, all that stuff, arrhythmia, whatever it is. Now, it's also this time I'm going to make sure the family is updated about how the patient's doing. Now, surgeons will always update the family about the surgery. Hey, we found this. And then as the ICU physician, it's always like, okay, where's the family? Can we get them back here? And then I update, hey, here's the big picture. Here's what's going on, right? This is the time where now they're more stabilized in the ICU. And, families always want to know, how critical is it, right? They usually, using the word critical helps people, being like, hey, they're critically ill or they're not critically ill. And you don't sugarcoat anything. You tell them exactly what happened. I tell them things I'm worried about. And you do. I find from my experience, you don't hedge on like, hey, well, this is going well. You tell them plainly what's going on. And if it's bad, it's bad. Okay. You tell them it's bad. You say, I'm worried they could die. They could die in an hour. They could. We're going to do the best we can. You just be very straightforward with the patients, with their families. So I make sure that they're updated. They know what's going on and that they're in the room as much as possible, as much as feasible. Now, I don't have time to talk about it, but now so many things can now happen in the ICU to a patient who's had traumatic injury. Okay. They now can die of a lot of different things. Okay. They can get what we call nosocomial infections. They can get a pneumonia. They can get an infection in their belly from having surgery. They can go into septic shock, 12 hours, 48 hours later. And that can kill them. They can get ARDS, acute respiratory distress syndrome, where they've had inflammation of maybe they aspirated into the lungs, now they have inflammation. They can die of ARDS a week later, despite all of our best efforts. So they have so many hurdles to go through to survive. And there's a lot. Pain control is another big thing. So if someone has rib fractures, can I please leave you with this? If someone has a bunch of rib fractures, they need an epidural, okay? They need an epidural. Rib fractures are a big deal. Sometimes they don't seem like a big deal because you don't need to fix them unless they have flail chests, which some surgeons will put in a plate to help with flail chest, which I won't dwell on that. But these patients need an epidural. Okay, the reason is if someone has rib fractures, they can't breathe deep, they can't get liberated from the breathing tube, from the ventilator. They'll get a pneumonia and then they'll die from that. When they get a thoracic epidural placed, it helps relieve their pain so they can take deep breaths. It'll help them survive, putting epidural. If I can leave you one thing, if you're like a practitioner in this area, advocate for a thoracic epidural for your patient with rib fractures who's had traumatic injury. They need it. But pain control is a big issue because traumatic injury is painful to the body. of course. So they have to have copious, generous opiates, lots of stuff. But then now they can get over-sedated, and now it's hard to liberate them from a ventilator and things like that. Ketamine, you reach for everything you can have. But sedation and analgosedation, analgesia, is also another huge, huge topic and challenge in patients with traumatic injury. And it also becomes an obstacle to their recovery. Their pain control, and then also being sedated from that pain control is an obstacle. So many things can now happen. But I'm going to leave that discussion with that. I hope it was helpful. This deserves hours of talking, this topic of trauma, anesthesia, and trauma surgery. But I hope it was helpful. I'll leave it there. All right, we're going to move on to an email from a listener. And this is from Rob, last name withheld. All right, Rob says, "Hello, ICU Doc. My name is Rob. I am an age that I'll withhold. I am from the UK. I am just listening to your episode on Donald Trump and fascism. That was an episode I did last week. I think it was episode, what number is it? It's episode 66 called American Fascism. You can go back and listen to that if you care about my political takes. Anyway, he said, Rob says, I listened to that. I got to say, I did support Trump before his second term, but seeing what he's doing now, it appears he seems to be picking on all his allies to all of Europe. Everyone seems to be in the firing line, especially Germany and the UK. J.D. Vance yesterday came out and said that the biggest threat right now in the world isn't Russia or China, but it's from the enemy within the EU and the UK. The UK, EU, and Germany are meant to be the USA's greatest allies, and it seems like Trump and Vance just want to put them down and belittle us. It's really quite alarming how much the mood has changed towards the USA from the Europe side. Trump wants to tariff the UK for what good it will do. The UK and USA and the EU should be standing together, but now thanks to Trump and Vance, it appears the USA wants nothing more to do with us. It's a very scary prospect. Listening to your podcast today about how Trump is a fascist, it suddenly clicked, and you are correct, Trump is a fascist, and I just hope that Trump comes to his senses. Thank you for your always thought-provoking commentary. As usual, it's such high quality. I hope you never stop making these social and medical podcasts. I know the TikTok has now finished, but hope you did this enough. Do this to continue. Many thanks, Rob. Rob, thanks for the email. I appreciate your perspective and your commentary, and I don't believe Trump will come to his senses. He's not a man capable of self-reflection. Yeah, I'll just leave it at that. Thanks for writing that in. And if you haven't listened to my episode, you can go back, episode 66, about American fascism, about the current woeful state of American politics. All right, let's move on to some books. As I said at the beginning of the podcast, I'm going to be talking about Genghis Khan. I know there's controversy about how to say his name, Genghis and Genghis. From historians that I read and audiobooks I listen to, it's always pronounced Genghis Khan, so that's how I'm going to say it. Genghis Khan and the Making of the Modern World by Jack Weatherford. So this book, talking about this book, let's back it up with a thought experiment, okay? Imagine a woman is kidnapped from her husband by a nomadic tribe, and she is forced into that tribe that kidnapped her, and then she's impregnated, she's raped. That woman, and now multiple pregnancies that she's had, and her 5 children from that tribe are then rejected by her own captors, and they have no home, and they live by a river, they fend for themselves, which is likely a death sentence in these ancient times, right? Having no community. And then imagine one of those children of that woman, a few decades later, unites millions of his own people under one banner, conquers a landmass from China to Hungary and to Baghdad, and institutes the largest empire that has ever existed in history besides the British Empire. I am describing Genghis Khan. That's what he did. And that's his origin story. And it's not that he led a revolution of the aristocracy, which, like the American and French revolutions, right? Those were aristocratic revolutions. They were revolutions by the aristocracy, at the behest of them. That was Genghis Khan. He was literally some poor bastard kid that lived by a river. It is one of the most incredible real-life origin stories that I've ever known, and that's what this book is about. Before reading this book, my impression of the Mongols was the following, okay? I wonder if you're a Western person like myself, you might you might have had the same experience. Here's the words I associate with Mongols. The Mongols: violent, horde, rapist, conqueror. After the 1600s, there was enormous, quote, Mongoloid racist scapegoating by Soviets, racists, Nazis, I believe, pseudoscientists, phrenologists, doctors, all sort of the intelligentsia of that day, which was fabricated to create the right narrative to bring Asiatic people more easily under Western colonial rule. So this skewed perspective that I have of Mongols before reading this book was directly affected by the anti-Asian races image that was carefully cultivated long before I was born, during colonialization. And that's what makes this book so important. All those racist stereotypes about Mongol crap, all that goes out the window when you discover what an incredible person Genghis Khan was and how amazing his empire was. Of course, no conqueror is actually like good, from like a traditional moral perspective. All the world conquerors throughout history were murderers, rapists, and power-hungry bad people. Khan is not really an exception. I'm not going to call him a good person. He literally murdered his stepbrother as a young man and did lots of other bad stuff to many, many people. But here's what sets Genghis Khan apart. Not only is his origin story incredible, but he very clearly united and liberated his own people while actually creating a relatively egalitarian empire with religious tolerance that sought to integrate other cultures and not abolish them. That is next level stuff. That's what makes him different. Can you say the same about any recent Western conquerors or colonialism? Of course not. When you compare Genghis Khan to other empires, I think he clearly was much more relatively peaceful, which shatters the stereotypes we have about him and the Mongols in our Western perspective. Genghis Khan took a bunch of tribes that were constantly at war, who performed routine kidnapping of women. He united them. He outlawed the vengeful practices that were destroying his own people. He outlawed the kidnapping of women. He totally destroyed the aristocracy, and he gained total control and made himself beholden to his own laws. He initially controlled an area about the size of Western Europe with about 1 million people. He got rid of inherited lineage and privilege and opened leadership up to anyone regardless of their background. He created a culture of absolute religious tolerance, full of Christians, Muslims, Taoists, Buddhists, and anyone else. He created taxes, but also made exceptions for the poor and for professionals. He created the decimal system for his troops and made one of the most dynamic and powerful armies in the world that used scare tactics and surprise rather than traditional siege wars of attrition. The success of his war tactics spread like a virus and completely upended warfare. His son continued much of the same tradition, but ruled from a capital city rather than on the horseback like Genghis Khan did. He created paper money, along with all the monetary policy that goes along with it. He created a universal alphabet for his enormous bureaucracy to communicate over large distances and many other cultures. And then particularly in China, the Mongols instituted lots of what would be considered social democratic policy, including education for all. They developed tons of science and astronomy as well as census taking. They were extremely pragmatic, way more than they were idealistic. They adopted mathematical and engineering solutions from all the cultures they conquered and then integrated them into the empire. The Mongol Empire very much influenced Western culture and has had a lasting impact today. One of the issues is that the success of the Mongol Empire depended on continued conquest, right? It consumed. They advanced through Kiev, Poland, Georgia, Turkey, Hungary, Egypt, and Baghdad, and spread all through China, as Genghis's heirs descended into a monarchical aristocracy, which ultimately led to the eventual demise of the empire, as well as the collapse of their economy and bad inflation. There was a lot of political infighting. This is after Khan died. And there was inheritance disputes. As it goes, there was a steady decline over 4 centuries. The later vilification of Genghis Khan by European colonists has become part of anti-Mongol and anti-Asian propaganda that you still see today. Anyway, very, very good book. It's called Genghis Khan and the Making of the Modern World by Jack Weatherford. I highly recommend you read it. All right, then I just want to mention one other book that I'll just briefly talk about. It's called The City on Mars. Can we settle space? Should we settle space? And have we really thought this through? It's by, I believe they're a married couple, Kelly Weinersmith and Zach Weinersmith. So this is a very extremely entertaining pop science book about the possibilities of colonizing space. And the authors are not shy about their opinion. And it boils down to this. There is little reason for humanity to colonize space at the current moment Why? Because space sucks. It sucks. And they say that in the book. They say it over and over again. It's very funny. They're like, because space sucks. The authors go over every argument of the benefits for colonizing space and basically tear them apart. No, there are not unlimited sources of materials on the moon, Mars, or an asteroid that would even remotely justify an expedition to mine them. No, the world wouldn't just spontaneously get rich from the bounty of space that is ripe for the taking. All the reasons that people put forth as benefits of space are literally already on Earth. All the ways in which humans suck on Earth will continue to happen in space, meaning they're bad behavior, right? Just because the moon has helium-3 or whatever doesn't mean it's in meaningful abundancy to justify an expensive mission to claim it. The authors argue there is zero economic reason to get resources from space. Currently, right? The authors drag out all the reasons why space sucks. There's no atmosphere, everything is dangerous, there's tons of solar radiation, and there's no gravity. We know absolutely nothing about the long-term problems of living in low gravity, let alone growing a fetus and raising children in low gravity. No one in their right mind should be trying to have children in space, the moon, or Mars. The data is just extremely lacking on the effects of space colonization on the human body. They talk about the best ways to colonize, which wouldn't be some domed colony, but probably trying to get by in a lava tube, which is a natural cave in the ground to protect from space radiation, and to try to create an atmosphere underground. There's an amazing discussion in this book about the politics of space colonization and the OST, which is called the Outer Space Treaty, and the extreme lacking of a durable space law. If countries try to colonize the moon, which does have some resources, is it their land? Is it that country's land? Does space sovereignty exist? Who controls a colony if it is owned by Elon Musk or Jeff Bezos? Do space colonizers want to live in corporate towns where now the very air they breathe is privatized? A billion more questions like this are just on the table and remain unanswered, while these moguls say they want to colonize Mars in 20 years. It's just absurd. And the authors, they bring that absurdity to your mind. This book is written by space dorks. They have the street cred to be both naysayers and alarmists. It's very entertaining, and I think it's a great book for the general public, and I highly recommend it. I loved it. It's called The City on Mars by Kelly Weinersmith and Zach Weinersmith. All right, that's it for the episode today. Thank you for listening. You can email me at icudrecmo@gmail.com, icudrecmo, ECMO @gmail.com. Email me whatever you like. Please tell me if you do not want me to read your email on the podcast. If you don't tell me, I will assume that I can, and I may. What was I going to say? Oh, please leave a review and rating on wherever you listen to this podcast. That helps the podcast to grow organically. And that's it. I'm going to have a book coming out on May 15th. I write sci-fi and fiction and a post-apocalyptic fiction. My pen name is Wick Welker, Wickwelker. My books are on Goodreads and Amazon. And I have a book coming out May 15th called Dark Prophet. And it's a sequel to Dark Theory, which is a big, sprawling science fiction fantasy epic adventure that I've been writing for the last couple of years. So you can check that out, and I'll have more details about that book. I'll probably do a giveaway in a couple weeks. But you can check out my books if you're interested. And that's all I got. Thanks for listening, and I'll see you next time.